and look at the initial process of taking you through the historical perspective of the epidemic. And there is abundant evidence now, which is now obviously accepted globally amongst scientists, that there was mutation of simian immunodeficiency virus, something that exists as a commensal or a normal infection or a normal organism in monkeys in Africa, and that crossed the animal-human barrier and then moved over from animal to human kingdom sometime in 1950s. Now this basically counters the usual rumor that we hear that HIV got transmitted or SIV got over to human beings in Africa because the African individuals would have sex with African green monkeys. This is quite a bit published in lay media across the globe. But the scientific investigations were conducted by Centers for Disease Control, Atlanta, United States, where scientist teams moved into Central Africa sometime in 1980s and tried to figure out what would have caused the transmission or movement of simian immunodeficiency virus from African green monkeys to human beings, and then got mutated to HIV. And the scientific team that went into the tropical jungles, tropical forests of Zaire, which is now known as Central Republic of Zaire. I'll show you the map in the next slide. And that's where we find that the African individuals, they don't have much of gardening or farming. They don't have access to livestock, so not much of employment. And the tribal groups will then go after African green monkeys as a source of protein. And they will catch an African green monkey, which normally looks like a langur monkey. I don't know in the region if you know those. And they will get this monkey every day, and then in the evening the groups, all the families get together. They would chop the carotids off and collect fresh blood that will ooze out on slaughtering the African green monkey, and that gets collected in a ball and goes across the entire group of 100, 200 people as an appetizer or a soup to begin with. So, and then of course the monkey is barbecued on an open fire, and the protein shared on. In the process of catching the monkey and then slaughtering the monkey and then moving on, I'll take the mic. Am I audible through across to all the sites? Can somebody say yes or no from different sites? Is the mic okay? The mic system okay?
Loud
yes?
And clear, Sarema, loud and clear.
Am I audible? Are you able to hear me across?
Yes, loud and clear.
Okay. Okay, I assume that you are all able to hear me. Okay. So this is a historical perspective about the movement of simian immunodeficiency virus from animal kingdom to human kingdom. Now, in a century, in 100 years, not many such infections move from the animal to human kingdom. Some of the examples that we know are now, of course, happening again in this century is the bird flu, where there is evidence that the virus is able to move from birds over to human beings, and then from human being to human being transmission, leading to a new pandemic that we know as bird flu or bird influenza. But before the bird one is the HIV AIDS epidemic, and before that we know several diseases, but they have taken very few in a century. It takes 2 or 3 such zoonotic diseases that would move on from animal to human kingdom, and HIV is one of them. So I think historically you will probably try to look at that. And here is the map of Africa, and what we predominantly see is this part of Africa, which is Zaire. Now this is known as Central Republic of Congo. And this is densely populated with tropical forests. And one of the main reasons where there's much of closer contact between the African green monkey and the human being. I was stationed here in Zambia, which is just at the bordering of Zaire, for 12 years, where we started describing the HIV epidemic early in 1982. So we are very familiar with what could have happened in terms of close contact between human and animals, and the zoonotic disease becomes then an pandemic. So the common transmission of HIV goes through body fluids, and the common fluids that we all obviously know about is blood, semen, vaginal secretions, and breast milk. Now, all these body fluids would have different concentration of the virus, but before we go on, let me try and describe you that HIV, human immunodeficiency virus, has several types of subtypes. We call them as serosubtypes. And they are given alphabet distinguishing characteristics, which would be HIV M, HIV N, and HIV O. Now, the most common type of HIV is classified as HIV M under the M category. The N is less common and primitive, and O is representing outlier. O represents outlier. And this O is again extremely primitive type of virus that actually occurred in human beings soon after the mutation from SIV to HIV. So within the main HIV type M, there are several subtypes, and these are denoted again between HIV 1 and 2, and then between them is HIV 1A, HIV 1B, and goes on and on to J and K. Now, this map that you see on the screen across, that map primarily shows you that the predominant types of HIV 1s, whether it's United States, whether it is Latin America, whether these are parts of Southeast Asia, there are different alphabetical variants of HIV 1, and they have a meaning. When you look at HIV, for example, B in the United States, it's more commonly transmitted through the IV drug use and the gay, homosexual, if you want to call it, or men having sex with men type of variation. Now, this subtype B is very difficult or less efficient to transmit through heterosexual act. The reason why HIV really got spread like wildfire in Africa, where there is a subtype C, is because it's much easier to transmit through the heterosexual route. Similar is that if you look at India, the predominantly another large epidemic with almost like 2.5 million people in India infected with HIV, almost 85% is subtype C, and very little is B, which is amongst IV drug users and gay men. As a result, we are now looking at also, for example, in Thailand, it's basically you have a subtype B and E, E for England. You have predominantly different formats, and similarly in Indonesia, there is quite a bit of HIV-B. Now, to re-emphasize that where you have a most predominant mode of transmission being through sharing of needles and syringes amongst intravenous drug users, it is predominantly subtype B of HIV-1. So we will say it is HIV-1B as a subtype. When it is heterosexual, of course, B also can go heterosexual, but The heterosexual subtype is generally HIV-1C, subtype C. Now, subtype C is further broken down into multiple of them, and it's known as C1, C2, C3, and goes on. The reason that we are seeing so many subtypes is because in an individual, in a human being who's infected with HIV, there are over 10 billion particles of HIV produced every day. 10 billion. I don't know how many zeros you're going to really add. 10 billion particles in an HIV-infected person produced every day. And 90-95% of those particles are taken care of by the circulating immune system or the antibodies that are already there. So whatever little remains then goes on and to infect newer lymphocytes or the newer immunity cells, and then the whole process goes on. The point I'm trying to make here is that whenever you have an organism that replicates into billions of particles on a daily basis, the replicative process can get corrupted. And in the corrupt practice, you have a lot of inefficient virus particles generated. So would also it acquire more surface antigen of other particles, and so would it mutate faster. And as it mutates and antigenic drift happens, we call it the antigenic drift of the envelope of the virus, the various subtypes will keep appearing. So we say subtype C in India is common, if it is subtype 1, whether subtype 2, subtype 3, and goes on and on. And to the extent now, the number of subtypes seem to have lost count. There are now 90 of these subtypes in the process. And while the subtypes are also happening, there are individuals who are simultaneously infected with two types or subtypes of the virus, HIV-1 and HIV-2. Now, if an individual has HIV-1 and within the period while the immune system is still developing, gets exposed to HIV-2 and also picks up HIV-2, the individual will have both HIV-1 and HIV-2 as co-infection in an individual. And while that individual is replicating, the individual keeps on combining the surface proteins of HIV-1 with the envelope proteins of HIV-2, and what produces are known as circulating recombinant forms of the virus. Now, I know I might have confused you with lots of these terminologies, and in the School of Public Health, a lot of you may not be exposed to virology, may not be exposed to immunology issues, but it's important to know that any organism that grows at the rate of 10 billion particles a day in an individual is likely to take on lots of corrupt pieces around in the circulation, produce newer forms. And when we get this kind of circulating recombinant is combination and recombination forms of the virus, it makes it extremely difficult later on to produce a vaccine that will then be effective in preventing or even a curative form of vaccine in individuals. We move on to, from the tough point of how the virus is and how it behaves, to a practical public health issue. And the issue is the level of the virus in a microliter of body secretions. Now, we know that most of the infections are carried in blood, and as a result, if you take 1 microliter is 1/1000th part of 1 ml. Now, when you take 1 microliter, in blood, there are likely to be something like 18,000 viral particles. We call them virion. 18,000 particles per microliter. And in semen, there are about 11,000 particles. In vaginal fluid, 7,000 particles. In the amniotic fluid, 4,000. And the least is in saliva and breast milk. So if one needs to expose a little bit to the virus, then the safest one is breast milk and, and saliva. I'm not saying we would like to go and expose to saliva of an infected person, but why should there be difference in the concentration of viral particles in the semen versus the vaginal fluid? The answer is that the semen goes through the prostate, and prostate is an endocrine gland. An endocrine gland, it breaks the entire cell with all its content to produce the liquid. As a result, there is more concentration of virus in semen compared to the vaginal fluid, which comes out from an exocrine gland of the cervix, and as a result, there is less concentration of virus in the vaginal fluid. But the issue of infectivity from infected blood is definitely proved and known, that if an individual gets infected blood from a person through use of shared needles or syringes, or whether as a blood transfusion, the risk of transmission is very, very high when blood is involved in the process. On the other hand, if it is semen, which is more concentrated, and woman being the recipient of the semen, it's more likely to be more infective as compared to the vaginal fluid, which an individual is likely to be exposed during sexual intercourse. Amniotic fluid is something that is more important from the baby transmission point of view, or in the hospitals where deliveries take place, and the hospital staff could be exposed to amniotic fluid and splashes. But the most fundamental question that comes across to people with public health is the likelihood of transmission of HIV through kissing. And that's why we want to show you that saliva carries a very, very low level of free form of virus, and it is less infectious, not because one particle cannot infect anybody. Let me be very, very clear that it's generally one particle of a virus, HIV, is enough to establish an infection in an individual. So to say that, well, because there is very little of virus in per microliter of saliva, that it would be not a risk for transmission. The saliva can transmit virus provided there are sub-factors available. Now again, it goes is the types of kissing, and there are a very number of sexual books that talk about the types of kissing, and the types of kissing that the medical anthropology knows are 64 types of kiss. And the best and the most riskier amongst them is the French type of kissing, where a cupful of saliva might be transmitted between two individuals. I don't expect the audience to be practicing this after the lecture is over, but there are 64 types of kiss that have been described in Kama Sutra. That's one of the scientific books of sexuality written 500 years ago. But there are at the same time also is how deep the kissing goes and how much abrasions or cuts happen. So to say that kissing is safe, I think it's safer, but it's certainly the risk of transmission is there. And the same thing also talks about breast milk, that breast milk from an infected mother to her baby could, and 1/3 of the transmission does happen between the mom to the child through breast milk. So with this we move on to the triad of infectious disease transmission. We know that it is between the host, agent, and the environment. Now, what are the human factors or the host factors that influence or propagate the HIV epidemic? One, of course, is a major cofactor that we know is the high prevalence of sexually transmitted infections, STIs. STIs have been there since the human being has been around on this planet. And the most common ones, of course, the prevalences have gone up and down, but there are predominantly the ulcerative and non-ulcerative forms of STIs. The ulcerative forms that most commonly occur are syphilis and chancroid and lymphogranuloma venereum. I'm sure you're familiar with these terminologies. And the ones which are non-ulcerative type, we are talking about the most common being gonococcal and chlamydial infections. And of course, there are remaining host of it. The difference between the presence of ulcerative genital ulcerative disease, we call it as GUD, genital ulcerative disease, which includes syphilis, chancroid, lymphogranuloma venereum, herpes, and all. The presence of genital ulcer disease increases the transmissibility of HIV between individuals by 100 times. By 100 times. Versus those who have discharges. We call it as genital discharges, whether it's a vaginal discharge due to chlamydia or gonorrhea or bacterial vaginosis, or whether it is discharges from male genital in terms of gonorrhea and chlamydia. And the presence of these discharging infections will increase the transmission of HIV in these individuals by 10 times. So, if you have three situations. Situation one is that there are individuals, the two individuals having sex, whether they are males or men to men and heterosexual, but they do not have any cofactor like STI. The probability of transmission will be that from a man to a woman, the transmission probability is 4 in 1,000, and the transmission probability from a woman to man is 1 in 1,000. So, in a situation where you have a man who's infected and has sex with 1,000 women, it's likelihood that 4 women will get infected from him. Another way around will be there is an infected woman who has sex with 1,000 men. Its likelihood is only 1 man would get infected, provided there are no STIs in any of them. Now, this doesn't mean that a person would decide to say that, okay, I'm going to have sex with 996 women so that the remaining 4 towards the end will not get infected with me, or other way around. It doesn't work like this. The statistics works differently. So in other words is that the point I'm trying to make here is HIV is extremely difficult to transmit, or HIV is extremely difficult to obtain unless people work very hard for it. So when they work extremely hard, it's a process of acquiring multiple sexual partners, and at the same time they have prevalence or occurrence of sexually transmitted infections. They have genital ulcers, they have genital discharges, and that makes the transmissibility increase 100 times. What it would mean is that if there is a man who is HIV infected and has a genital ulcer disease, for every 100 women that he has sex, or every 100 times he has sex, the probability of infection will be 4 in 100 and not 4 in 1,000. Maybe these figures will confuse you a little bit, but I think I made my point. And the point is that HIV is difficult to transmit. It requires a lot of effort, and people who are getting infected have made a lot of effort to either transmit or acquire it. It's fortunate because the amount of sexual activity that happens between human beings is just phenomenal. And yet we are now talking of, and we'll show you, there are 33 million people across the globe, which is the total population of the globe now being 6.2 billion people. And we have amongst them 33 million who are HIV infected and living with HIV. So there is obviously a disconnect or disproportionately less amount of infection as compared to the amount of sex that is normally happening. Knowing about HIV and the perception of risk is another issue. People know about HIV, but how many of these individuals apply that knowledge to have safer sex? Now, when we talk about safer sex, we are talking of individuals. What is safe sex? Let's define safe sex. Safe sex is defined as sex between individuals who are mutually faithful and who have not been exposed to sexual intercourse with anybody else. That is safe sex. Safer sex is where you have taken adequate precautions and when sex is happening with multiple sexual partners. Now, to apply that knowledge about HIV and STI to ensure that there is no disease transmission is a behavior that takes phenomenal amount of effort on individuals, and it's not happening. That's despite all that. So there is plenty of knowledge in communities, but for them to change behavior to have safer sex would take much more beyond than what we have been able to do so far in the last 30 years of this epidemic around. Next point is about multiple sexual partners. And what we really need to look at is a fundamental that why people would like to have multiple sexual partners. Now, that we have not understood. Neither has the sexuality research been able to show us why people would like to have multiple sexual partners. People can have multiple friends, but people having multiple sexual partners where there's sexual intercourse is something that is extremely mutual between individuals. And sexuality research probably has not gone into enough depth to understand where that aberration comes from. And lastly is the low use of condoms, and that is both for males as well as females. There are, I think one of the slides will later show you the type of female condoms. For those who have not so far seen, that there are condoms for females now widely available in the national programs, including in Indonesia, and I'm sure it's in Philippines, I've seen them. And in Bangkok, there are female condoms in abundant supply by the national programs. Despite the availability of condoms which lead to safer sex, as I defined, the use of condoms remains extremely low, and then we'll discuss this again after a few minutes. But we move on to the next, and the point that we want to discuss now is what are the environmental factors that facilitate transmission of HIV? Everything that's probably an aberration, we always blame it on to poverty, but probably that is right. Poverty is associated with low educational status of people, low literacy rates, at the same time low health status of individuals. So there are all these linked areas, and when we are talking of MDGs these days, Millennium Development Goals, Millennium Developmental Goal number 1 is alleviate poverty so that we alleviate lots of socio-economic and cultural aberrations or cultural defects in our societies. There is again a low status of women, and we have, I think, always talked about gender, and where does the gender imbalance cause most amount of aberration other than the transmission of HIV and STIs? There's displacement and violence and migration. Again, the individuals who migrate, or they are displaced internally or externally. An example that actually I was reading recently is that Indonesia has the world's largest population that has migrated. So they are migrated from Java to different provinces of Indonesia and countries around, but there are 110 million internally displaced individuals, and that's an amazing amount of figure. And obviously people are displaced not probably because of the social conflict, but more of economic needs. At the same time now, there are war zones and violences which cause massive migration and displacement of people, and that itself makes women more vulnerable. Women who have moved to newer areas and do not have jobs and do not have economic security are more open and vulnerable to sexual violence and sexual infections, and HIV is one of those outcomes. And lastly, the stigma and discrimination against sexually transmitted infections, and that includes HIV. And as a human race, we've been very judgmental, and judgmentality goes on that anybody who gets a STI or anyone who gets HIV is then taken over to the moral levels, while the ideal scientific situation would be that disease should be left out of the moral areas. Then I think it's easy to get the stigma and discrimination out of our way. So here is how the waves of HIV epidemic happen. And there are these three circles. The core circle, the purple one, is talking of core groups, the individuals who are practicing high-risk behavior. Now, high-risk behavior is individuals who are having sex with men, or individuals who are having multiple sexual partners in the heterosexual area or in the same MSM areas, or individuals who are IV drug users. So they are core group, and core group generally is smaller. And then there is a bridge population generally of clients who go to sex workers and take the infections back to their homes and take it back to women, and the women then pass it on to their children during pregnancy. So there are these three different areas. The core groups are generally smaller and much easier to address, and then it transmits to the general population around, to the universe, through the bridge population. Mainly, again, are the men who visit sex workers and go for paid sex. And these will keep on producing waves of HIV epidemic. So it is not like an example where we talk about one country having one epidemic, and then the epidemic is something that is moving on. It is not an epidemic that is moving on in one direction. Here we are talking about an epidemic that is addressed. It will be under control for a while, and then it produces another wave after a few years, and maybe produce multiple waves in different provinces and states of the country. I think I will address that a little bit later, but we move on to the routes of transmission. We have already talked quite a bit about the sexual contact, male to male, or female to man, or female to female. And when we talk about female to female, we are talking about lesbians. And the very low level of sexual transmission has been documented between female to female because of use of sexual toys or the orogenital sex that happens. In terms of blood exposure, is the transfusion of infected blood or blood products. There's occupational exposure that might happen in the hospitals because of the needle stick injuries. And of course, the most predominant one is the injecting drug use and the needle sharing. There is perinatal transmission that we talked about, transmission from mother to baby during pregnancy, but most of the transmission occurs at the time when the baby is being delivered. And that's the time where there is a lot of amniotic fluid and a lot of bleeding from the mom, and the baby is likely to aspirate or suck that blood. And then, of course, breastfeeding. And breastfeeding normally goes on between for 6 months to 18 months in different cultures, and there will be gallons and gallons and gallons of breast milk that a baby drinks from a mom. And in this case, if the mom is infected, there's going to be a lot of virus every day. But the 1/3 of perinatal transmission now is being documented to be through breast milk transmission from the mom to baby. Okay, a quick word about all these figures. They are very boring, I know, these figures, but at least we would remember that 33 million people across the globe are living with HIV, and so HIV has got a big epidemic, but at the same time the population is much bigger, and mostly it's adults. 50% of them across the world are women, so women are sharing the burden almost equally, if not disproportionately higher than the men. And there are children also who are innocently receiving the transmission in between. But each year, despite 25 years, 27, 28 years of this pandemic control, there are still 2.5 million new people who are getting infected every day. And, 2.5 million people getting infected every year. And every year, out of the 33 million, 2.1 million are dying. And this is despite the